So, good afternoon to all of you, and it is a pleasure to be back again on Midstream 360. I am Dr. Praveen Chandra from Medanta Medicity Hospital here in Gurgaon, India, and along with me is Dr. Abhinav, who is going to be in this case today to take it forward. So, this is a very interesting situation, and he's going to tell you about the clinical history of this patient.
Yeah. Hello, everyone. So this is a 66-year-old female. From last 3 months, she had significant angina, which was managed medically earlier, and she underwent angiography as well. Outside, she was kept on anti-anginals, maximum optimum therapy, but despite that, she had significant angina. She has comorbidities in the form of diabetes, hypertension. She
Bad
had
lung
OSA,
disease.
bad lung disease as well, COPD. And so here we started with the angiography, and it revealed the same thing, having the circ having almost 70 to 80% distal lesion, LED having almost 80 to 90% mid lesion. So it is a fibrotic lesion along with some calcium inside. As we have tried crossing the IVUS in the LED, but it was not crossing. Now, sir will forward the case.
Okay. So here you see that on angiogram we have a long disease in the LAD. There is a disease in the first OM, which is a very big OM, and then the distal circ is having some narrowing in the range of about 50-60% and maybe up to 70% at some places. And the right artery is non-dominant, but it is having some disease. So in this, you can see that the LED is the tightest lesion, which is creating this symptom. And she has been, advised surgery earlier in many institutions, and then she was seen by some surgeons, but they all refused surgery because of her bad lung disease. So then she was brought here, and now we see that the LED is the culprit lesion, but certainly we also need to look at the circumflex and the OM. Yeah. So here you can see that we have wired the LED, and also now we will assess that whether this OM and the circumflex is significant or not based on the FFR. So we have put the wire in the OM, as you can see here, the first big OM, and this wire is in the first big OM, and the IFR values, as you can see, is 0.97, 0.95, which is clearly normal actually. Although on angiogram it was looking like at least 70%, 80%, but it is absolutely okay. So we don't need to really touch it, because if we have to touch it again, there was an issue whether we should have put a stent, but we had planned to do a cutting balloon and a drug eluting balloon in case we had to intervene. And I'm going to inject adenosine now, and this is 200 mics of adenosine, and you will see some bradycardic effect. And here we have some bradycardia. Okay, so how much is the FFR? Let's have a look. So the FFR is still 0.88, 0.87, and the FFR is also negative, clearly negative. If you look at the screen, it is clearly negative. Okay. So I'm pulling the wire back from the the OM, and I will use the same wire to see if circumflex is significant or not. Check, please. No, I can't see
Distal,
anything.
distal.
Great. So we have put the wire in the circumflex. Yeah. Okay. Yeah. Okay. So let's look at the values here. This is significant. Okay. So this value is significant here. As you can see, that it is coming to about 0.6. So this lesion in the distal circumflex is definitely significant, and we might consider to do an intervention here, because this is the IFR and it is 0.56, 0.6, which is definitely significant. So the OM, which was looking more, was negative, and here we have the distal circumflex where we were not very suspicious. We see, but of course we saw that it is a long lesion. So this is a long lesion behaving like a tight lesion now, and we will definitely treat it and see how it goes.
15 balloon.
So the plan is to do a epicranial, please. The plan is to dilate this LED first with a normal balloon, high pressure balloon, and then we will see this is 2.25 into 10,
2.5, 15.
15. Okay. So it's a 15 millimeter balloon. And now the question is whether we should put a stent in LED or do a drug eluting balloon. We will decide. Check, please. Take a shot. Okay, go up. 1, 2, 3, 4, 5, 6, 7, 8. Deflate. So you saw that the balloon moved a little bit, slipped down because of the long lesion here. Go up. 1, 2, 3, 4, 5, 6. Again, it is slipping. Deflate. So it is a very fibrotic kind of lesion. Check a little bit. No, I'll put it be here. Okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Deflate. Again, it is moved. So you can imagine how fibrotic this lesion is. Go up. 1, 2, 3, 4, 5, 6, 7, 8. Now it is staying a little better. 12. Okay. Deflate. Okay. Take a shot. Okay. Okay. So this is the time we can do IVUS now.
Yes.
Although, and maybe some more dilatation here in the distal part because that balloon didn't stay there. Go up. 2, 4, 6, 8, 10, 12. Deflate. Okay. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Deflate.
Proximally, there was also in I was here.
Check, please. Okay. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Deflate. 12. So we are doing serial dilatations in this entire length of the vessel. Deflate. Using 2.25. Yeah. Yeah. Yes. So let us do IVUS now. So we'll do an IVUS. Here the lumen is small again, not too small. And here is a normal segment. Okay.
2.5.
So we can take a 2.5 millimeter cutting balloon, 2.5, 15, please, and do a cutting balloon here to see how it looks. And if we are able to get a good lumen without any major dissection, we might consider doing a drug eluting balloon also. Okay. So here it looks okay. The position of this balloon is okay. Yeah. What was the? Okay, this is a BMW wire. Go up. BMW wire in the LED and the FFR wire in the go up 2, 4, 6, 8, 10, 12, 12. Okay. So here we are dilating with it up to 12 because there was some calcification. Well, 13, 14. 14. Okay. Deflate. Okay, check please. Check, check, check. Okay, go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14, 16. Okay. Deflate. So at 16, it almost becomes like 2 point, how much? 75,
2.75.
2.75, 2.8. Check now. Okay, go a little bit back. Okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14, 16, 18. Okay. So this is a Wolverine cutting balloon going up to 18 atmospheres. Deflate. Deflate. So we have done serial dilatations. This looks quite good.
At bifurcation, there is some.
Yeah, there is some dissection there at the bifurcation with some luminal effect maybe, but otherwise this vessel is very well dilated now.
Mm.
Yeah,
Yes.
this is fine. Check again. Yeah, maybe a little bit.
No, sir, it's fine.
It's fine. Just
Distally adjust.
okay. Check please. Yeah, go up. 1, 2, 3, 4, 5, 6, 7, 8. Okay, so the expansion has happened at 8 atmospheres epicranial, and you can see that the proximal edge is appearing bigger than the distal edge because it is a tapered stent, 3 to 0.5. Okay, and the expansion is good because we did a good amount of dilatation with cutting balloons at high pressures. Deflate, please. So it prepared the lesion bed reasonably well, and so this was up to 8 atmospheres.
Yes.
Okay, and the nominal is go up 1, 2, 3, 4, 5,
9.
6, 7, 8, 9, 10, 11. Okay, deflate. Okay, so pull back. So now you can have a look at the IVUS. So the distal margin is very good. Stent is fully expanded. Lumen is good. We really don't need to do any post expansion here where we are. Okay, so we are
Diagonal.
at the bifurcation, and even the proximal looks great to me. Yeah, it's quite
And
nice.
landing is also set.
So here we can do some dilatation with a 3 mm balloon because there's some little bit of stents hanging there. Stent starts. I'll take a 3 mm balloon and do the post dilatation. Okay. Go up. 2, 4, 6, 8, 9, 10. Okay, deflate. So we have done the dilatation with a 3 mm balloon in the distal segment first, and then we will go to slightly higher pressures here because this is a segment which is having a good size. Go up 2, 3, 4, and you can see on the stent boost. This is a line online stent boost from Volcano. How much? 12,
Yes.
14. Okay, deflate. Okay, so stent looks very well expanded.
Center.
Solution central, please. Check, please. Okay, so it is going gradually. Okay, go up. 1, 2, 3, 4, 5, 6. Okay, so I won't go to high pressures here.
Yes.
So it has given up at 6. Very nice. Deflate. So this is phenomenal. The IFR has improved from 0.7 to
It's all
8.82, which is much better, 8.3. And so the values are much better now.
0.83.
How much? 0.83, 0.85. Okay, let's give some nitro, please. Yes. Yes. So yeah, this question, somebody put up that, what about the side branches? So let me tell you, this tapered stent, which is the one which we use, the Merrill Morph stent, and it has an open cell design. So that is why the you know
30 mm.
the side branches are very well preserved, and these patients do very well with it.
35, 40.
40, 40 is fine. So we can take a 40. So I'm taking a 40 mm drug eluting balloon, which is a 2.540 solution, which comes from Medalliance. So this is 2.25 into 40. Yeah. Okay. Yeah. So we are on the same wire, which was the FFR wire, and doing the whole intervention on the same wire. Okay. I think we are fine.
Yes.
Okay. We can check again a little bit. Yeah. Okay. Go up, please. 2, 4, 6, 8, 10. Okay. So now this is a, you can remove it so that we see it a little bit better. Yeah, you can see that it's a balloon 2.2540, which has been inflated up to 10 atmospheres. We can go up to 12. 12, please. 12. Okay. So we'll keep it for about 1 to 2 minutes. If she can tolerate, we'll go up to 2 minutes. We can now check again, finally, with the same wire here connected, and we'll look at the, yeah.
NTG.
Yes. So we have, two, three types of drug-eluting balloons here. What is this? Nitro?
NTG. Yeah.
Okay. So one, we have the Magic Touch, which comes from an Indian company, Concept Medical, which is also a sirolimus eluting balloon. Then we have a paclitaxel eluting balloon, which comes from iVascular. And then we also have Sequent Please, which is a paclitaxel eluting balloon. But let me tell you, our dominant balloon usage today is sirolimus eluting balloons. So this looks quite nice to me. And with this long balloon, the result is quite nice. And the vessel flow is good. We don't see any major dissections. So I think we can leave it.
Yes.
Yeah. So I think we are done. The IFR value is above 0.9, as you can see here, 0.92. And so it is nice. We will take the wire out. Okay. Yeah. And with this, I think we don't need to do anything further. Show me the last shot, please. Last shot. Yeah. So the LED is looking fine. And we can take another shot of the LED if you want. AP can. Yeah, in fact, I see that the only shortcoming is
Epicranial.
if in case the dissection is significant, then you cannot use a DEV. But if the dissection is up to type 2 dissection, I don't really worry about it. And up to type 2, yeah, type B, type C dissections, there is no problem. Okay. So everything looks good. And you can see that the circumflex is looking very good now. There is a minor dissection which will heal up on its own. Okay. So I will take this everything out, and all the vessels are flowing nicely. There is no issues. No, so we didn't go up that high. So we did. So somebody asked this question whether the plaque may shifted to the OM. Actually, we didn't go up that high, and we were only in beyond the OM, so that part was okay. So we are done here, and the result you saw, we are very, very happy, and thank you very much. And I hope to see you again next week. All the best.